Okay, so I'll get started on the Journal Club today. My name is Lucy Kopecny. Today, the study that I wanted to look at is the diagnostic yield of uroendoscopy compared to ultrasonography for evaluating lower urinary tract disorders in dogs from the Journal of Veterinary Internal Medicine. And one of the reasons I was interested in looking at this is I often come across in clinical practice questions about what additional value cystoscopy will add to patients who I'm seeing for lower urinary tract signs and lower urinary tract disease. And I think that this paper is helpful in giving us some additional information about that. So, just as a little bit of background that this paper discusses, of course, cystourethropy and vaginoscopy, which together in this paper they call uroendoscopy, is very commonly used to investigate lower urinary tract signs and disease in dogs, and then used to perform interventional procedures such as laser ablation of ectopic ureters. And we know from previous studies that both cystourethropy and CT have greater sensitivity for identifying ectopic ureters than both excretory urography and ultrasonography. In terms of the benefit of cystourethropy in dogs with recurrent urinary tract infection, this is much less certain. There was a recent study by Lido et al. In dogs with recurrent urinary tract infection, which looked at a broad range of dogs who presented with that found that about 85% of dogs had abnormalities, though some of these abnormalities were non-specific findings like mucosal edema or lymphoid follicles. And other abnormalities were vestibulovaginal septal remnants, which the clinical significance of that for individual patients is still overall uncertain. So the objectives of this particular study were to compare the agreement between the diagnosis at cystourethropy and ultrasound in dogs who had presented to lower urinary tract for lower urinary tract signs as well as lower urinary tract disease, as well as to evaluate the lower urinary tract endoscopic findings in dogs with lower urinary tract disease. And the authors hypothesized that, excuse me, dogs with recurrent urinary tract infection would have the highest agreement between cystourethropy and ultrasonography. This was a study from the group at UC Davis, and they evaluated the records of dogs between January 2014 and December 2019 who were undergoing uroendoscopy for lower urinary tract signs and lower urinary tract disease. And they included dogs who had had uroendoscopy performed no longer than 60 days after their ultrasound. They included the lower urinary tract ultrasonographic diagnoses for bladder and urethra in male and female dogs, and the uterine stump and cranial cervix for female dogs. Any abnormalities outside of these areas that weren't able to be viewed with an ultrasound weren't included. So this meant that, for example, because vestibulovaginal septal remnants weren't recorded, aren't able to be visualized with ultrasound, they weren't recorded as findings. Also, the authors excluded any non-specific endoscopic findings such as mucosal edema, glomerulations, and lymphoid follicles, because these weren't considered to change the management of patients or provide a definitive diagnosis on their own. So if uroendoscopy provided additional clinical information or it identified the absence of an abnormality that had been found on ultrasound, they considered the cases to be in non-agreement. The authors categorized the indication for the ultrasound, and this was based on what the primary clinician had defined as the initial reason for their ultrasound. And this included dogs with urinary incontinence, stranguria without other lower urinary tract signs or urinary tract infections, recurrent urinary tract infection without urinary incontinence, considering that in dogs with urinary incontinence, that would be the primary cause or an important factor in their recurrent urinary tract infections, a suspected mass lesion, either in the bladder or proximal urethra, hematuria without lower urinary tract signs or urinary tract infections, multiple lower urinary tract signs with an undefined cause, and then other non-lower urinary tract indications for the ultrasound, such as penile bleeding or vaginal discharge, or that the patient had presented for a different presenting complaint, such as vomiting, and then an abnormality in the lower urinary tract had been identified. The authors used descriptive statistics to describe the groups, and then Cohen's kappa coefficient was used to assess agreement between the final ultrasonographic and uroendoscopic diagnoses with, standardized assessments of the degree of agreement used as per the table in this slide. Overall, there were 237 dogs included. 139 or 59% of these were female, and 98 or 41% of these were male. The most common breeds that were included in the study were Labrador Retrievers, Golden Retrievers, and German Shepherds. And the median time between ultrasound and uroendoscopy was 1 day, although the range was from 0 to 60 days. Overall, the agreement between ultrasound and uroendoscopic diagnosis was considered moderate for all dogs, with a kappa coefficient of 0.6, with a 95% confidence interval ranging from 0.52 to 0.68. And they found that uroendoscopy provided clinically relevant diagnoses and findings in 29% of dogs included. When you break this down a little bit further to the most common causes or the most common reasons that an ultrasound had been performed, this meant that there were pertinent uroendoscopic findings in 42% of dogs with stranguria, 29% of dogs with urinary incontinence, and then just 13% of dogs with recurrent urinary tract infections. So looking at this table, which is from the paper itself, looking at the kappa agreement between the uroendoscopic diagnoses compared to the ultrasonographic diagnoses, based on the indication for the ultrasound, we can see some of those statistics that I just briefly went over, with the degree of agreement varying from moderate for dogs with urinary incontinence and stranguria to substantial in dogs with recurrent urinary tract infection, and then fair agreement when we get down to dogs who have hematuria. I think one thing to take into account here is that while we see that a number of these indications for ultrasound have moderate to substantial agreement, because of the small numbers of dogs in this study within the different disease categories, the confidence intervals for some of these are quite wide, which suggests that the results could be different, I guess, compared to if a larger population was evaluated. The authors also looked at the kappa coefficient, so the degree of agreement between ultrasound and uroendoscopy based on male and female dogs. And I think it's interesting here too that we see that although the degree of agreement is considered fair for female dogs with urinary incontinence, this was substantial for male dogs. And then similarly in dogs with stranguria, the degree of agreement was substantial for female dogs, but only fair for male dogs. And the authors discuss this a little bit later. But the other causes, or the other primary indications for ultrasound, the degree of agreement was much more similar between male and female dogs. In terms of the reasons why there was a lack of agreement, between ultrasound and endoscopy, this particular table summarizes this, and just to focus on the causes of urinary incontinence and stranguria, we can see that for dogs with urinary incontinence, 11 dogs were thought to have an ectopic ureter based on their ultrasound, but this was not confirmed based on cystoscopy. And then similarly, 4 dogs weren't identified as having an ectopic ureter on ultrasound, but were found to have one on endoscopy. One of the big factors in the difference in dogs with stranguria between male and female dogs was the presence of a urethral stricture. This was predominantly found in male dogs in the study, and this accounts for the lesser degree of agreement for male dogs compared to female dogs when the primary indication of the ultrasound was stranguria. So just to look a little bit further into some of the most important causes of lower urinary tract signs or disease. So for their group of dogs with urinary incontinence, the median age was 1.5 years, although this ranged from less than 1 year of age to 14 years of age. And they had 65 dogs in this group. So this was the biggest group that they had. As I just mentioned, there were ectopic ureters suspected on ultrasound, but not present on cystourethropy in 11 dogs, and then 4 dogs had ectopic ureters identified on cystourethropy, but not on ultrasound. There was moderate agreement for dogs with urinary incontinence less than 2 years of age and greater than 2 years of age. So no significant difference there in terms when you think about the different age groups, even though the group of dogs less than 2 years of age, likely considered more likely to have an ectopic ureter, which in this particular study was commonly, thought to be more commonly thought to be present, and then was not present compared to the other way around. For dogs with recurrent urinary tract infection, the median age of dogs presenting for this was 3 years, again with a range of less than 1 year of age to 11 years of age. The agreement between uroendoscopy and ultrasound was similar for dogs less than 2 years of age and greater than 2 years of age. And overall, only 3 out of 30 dogs had abnormalities that weren't detected by ultrasound, but that were detected by uroendoscopy. And if we just go back to the table here, we can see that, 4 out of 30 dogs, we can see that there's finding of absence of a urethral remnant suspected on ultrasound, mass lesions in both the bladder and urethra that were identified, and then a patient with a rectourethral fistula. So in terms of the discussion, I think what we can see from this study is that the agreement between ultrasound and uroendoscopy differed between different indications for the ultrasound. And what this really emphasized to me was that it's important to take into account the presenting complaint as well as the signalment in dogs with lower urinary tract signs or disease when recommending uroendoscopy. And importantly, in dogs with urinary incontinence, 29% had abnormalities that were identified only by uroendoscopy that change management, such as the presence or absence of ectopic ureters. So suggesting that uroendoscopy plays an important role in diagnosis, particularly in dogs with urinary incontinence. In dogs with stranguria, about 42% had findings on uroendoscopy that differed to those on ultrasound. And in male dogs, this highlights the importance of uroendoscopy, as most of these dogs had a urethral stricture, which would have been unable to be identified with an ultrasound. In dogs with recurrent urinary tract infection, the agreement between ultrasound and endoscopy was 87%, so a high degree of agreement. And when we look at the human literature, we can see that this is similar. And this is what I wanted to delve into a little bit more, just because these are the patients who I often have more challenges in terms of determining the benefits of further investigations such as cystoscopy for when I have a dog presenting with recurrent urinary tract infection. And in this study, which is an older study, in women with recurrent urinary tract infection, only 9 out of 118 or 8% had pertinent endoscopic findings, and 7 of these women were older than 50 years of age. And based on the findings of this study, they suggested that women with no risk factors for urinary tract infection had a negative predictive value of 93% for normal cystoscopy, and that women without risk factors for recurrent urinary tract infection and normal imaging could have cystoscopy omitted. The study considered clinical risk factors for recurrent urinary tract infection, including things like having hematuria, pyelonephritis, calculi, being diabetic or elderly, an atypical presentation of urinary tract infection, malignancies, previous major pelvic surgery or radiation, hematuria or fecal urea, and diverticular disease. And so this gives us a bit of an indication, of some of the things that we may be more likely to be interested in as veterinarians as risk factors that might suggest the importance of cystoscopy. There are two other studies as well that have looked at the evaluation of cystoscopy in recurrent urinary tract infection. And again, we can see in this particular study that in the highlighted portion here, that only 3.8% of cases had abnormalities uniquely identified on cystoscopy that were missed on other imaging modalities. And that when imaging is normal, cystoscopy is also normal in 94% of cases. So suggesting that although there are a small number of patients that will benefit from cystoscopy, for the majority, this isn't the case. And then similarly in another review, they found that cystoscopy is of less value in patients with recurrent urinary tract infections, particularly if they don't have any evidence of other disease such as upper tract disease or a gynecological problem. In the veterinary literature, as I mentioned earlier in the presentation, Lido et al. Published a study on transurethral cystoscopy in dogs with recurrent urinary tract infections. In this study, 85% of them had abnormalities on cystoscopy, which included the presence of mucosal edema, a vestibulovaginal septal remnant, lymphoid follicles, a short urethra, and ectopic ureter. And although this study suggests that cystoscopy might have more value based on the number of patients with abnormalities, it is difficult to compare to the present study just because, as I meant, different cystourethroScopic abnormalities are reported. So in the present study that we're talking about today, abnormalities such as mucosal edema, lymphoid follicles weren't reported. And then in this study by Lido et al., dogs with urinary incontinence as the primary abnormality weren't evaluated separately. They're all included as a group in dogs with recurrent urinary tract infections. And as we can see from the study we've looked at today, there are likely to be differences between dogs who have, just recurrent urinary tract infection compared to dogs who also have urinary incontinence in terms of the additional value that cystourethroScopy adds to these patients. But it's nice to have this additional information from this particular study by Lido et al., as to what we're finding in these patients overall. Again, in this study, they also reported that 53% of dogs underwent correction of their anomalies, which included correction of vestibulovaginal septal remnants, UVJ stenosis, ectopic ureter, urethral septal membrane, ureteral seals, bladder polyps, and removal of bladder stones. Again, a little difficult to compare to the present study because vestibulovaginal septal remnants weren't evaluated. But it does suggest that, of course, there are findings in this population of patients, whether or not some of them, like a vestibulovaginal septal remnant, are contributing to the risk of recurrent urinary tract infection, but are abnormalities present that are able to be corrected. In terms of the limitations of the present study, of course, it's a retrospective study with possible selection bias. So, for example, potentially older dogs with urinary incontinence, most likely to be due to USMI, may have been less likely to have a cystourethroScopy recommended. And I think in practice too, uroendoscopy is often performed with a concurrent retrograde positive contrast, fluoroscopic cystourethrogram. And I think it would also be interesting in the future to look at how this changed the agreement between ultrasound, cystoscopy, and fluoroscopy, and whether additional abnormalities may be identified in different groups of patients. If fluoroscopy was also evaluated and compared to ultrasound. So I think the key takeaways for me from this study are, in terms of my clinical practice, is that cystourethropy is certainly a very helpful tool in investigation of lower urinary tract signs and disease in dogs, but of course is case dependent and important to take this into account when recommending this. I think, of course, not evaluated by this study, but one of the most important reasons for doing cystourethropy in some of our patients is that it also allows correction of abnormalities like ectopic ureters. And so it has value beyond just diagnosis, but also in treatment. And I think this study, also supports that likely in dogs, similar to in women, cystourethropy is less useful for investigation of recurrent urinary tract infection, without having other indicators that, suggest that there might be particular risk factors for an individual patient. So that's all I have today. Did anyone have any questions or any additional thoughts, on this study and cystoscopy?
Hi, this is Rachel, the pathologist. And it's not the question specifically for this. I guess I'm always looking at, not always, I often look at kidneys that have evidence of maldevelopment or dysplasia, and there might be some suggestion that the lower urinary tract is also involved. And I usually try to say that they should probably do some type of diagnostic imaging, but I'm wondering if I should be more specific. And I mean, most of these dogs have had an ultrasound, but having more like quote unquote reflex nephropathy, something like that. Like, what would be your, like, what terminology should I use for suggesting next steps and mark up those cases?
Yeah, that's a good question. I guess in terms of things like reflux nephropathy, I don't know that that alone would be necessarily identified just on cystoscopy. And I think that in those cases, that's likely where there would be more benefit to additionally doing like a fluoroscopic cystourethrogram. And if there's anyone else on the meeting, they can chime in. But I'd be saying that again. I think that cystourethropy wouldn't meet, confirming that reflux nephropathy is present. But I think certainly doing a contrast study, would be probably the best way that we have now of indicating whether that would be present for those particular patients.
Are there practices where cystouroendoscopy is much more easy to do than doing contrast studies? Like, that's what I'm wondering, if I'm asking them to do something so technologically advanced that they are just going to laugh at me.
Yeah, that's a really good question. I think certainly, obviously, cystoscopy is simple to do on its own. It's a little bit of additional effort to do with fluoroscopy, but I think that for a lot of practices, I guess, that do a reasonable amount of cystoscopy, it's probably fairly readily possible to do a contrast study as well at the same time. But it would add, I'm sure that all practices don't necessarily have, fluoroscopy available or aren't necessarily trained in interpreting that, even if they were to do it.
Okay, thanks. That's helpful.
It's a good question.
I'm always like asking if I'm asking them to do too much, but and that's why I kind of wanted to speak up. Okay, thanks.
Yeah, and I guess you can always make the recommendation to them, and they can always refer to a bigger center if they're unable to do something like fluoroscopy in addition to cystoscopy. Did anyone else have any other comments?
Go ahead, Dr. Dunn.
Hello, can you hear me?
Yes.
Yes.
Okay. Now, thanks for that review. I was wondering if you saw, and because you're talking about women, do you have any feeling for maybe pediatrics or younger patients? Because in our study on transurethral cystoscopy for UTIs, we didn't have enough patients. I think it's always one of the problems we have. So you don't want to create too many groups. But when we're looking at our younger patients with UTIs, we had kind of a higher yield of actual anomalies that we were able to correct compared to that 7 or 8 year old dog that had recurrent UTIs that we scoped and then really kind of didn't see a whole lot. Or things at least that we could act upon and correct. So I was just wondering if you, through the literature review and that in people, was there a difference in pediatric versus adult women? And if you, in your practice, if you see any kind of difference, because I do think that might play a role.
Yeah, thank you. That's a really good comment. And I didn't actually look at the value of pediatric versus, adult investigation of, recurrent urinary tract infections. But my clinical impression would be similar to yours in that when I have a younger patient who has recurrent urinary tract infections, and of course, particularly if they have other lower urinary tract signs like urinary incontinence, I think I'm much more likely to find an endoscopic abnormality, and also much more likely to strongly recommend endoscopy in those particular patients compared to in, an older female dog who develops for example, recurrent urinary tract infections later in life without having them as a younger dog. It would actually be very interesting to look at the literature, and it probably brings me to think that I should take a look at what the pediatric literature says, but I imagine would suspect it would be similar to I guess what our clinical impressions might be.
Well, I guess if there's no other questions, we'll go ahead and end early. Thank you so much for the presentation.
Thank you.
Have a great day, everybody.